Welcome Dawn O'Connell, the Assistant Secretary for Preparedness and Response at Health and Human Services, to the stage.
Dawn, thanks for joining us this morning. Okay, the pandemic is officially over. What were the lessons learned, and how do you see the future? Because another one's going to come down the road, hopefully not in our lifetime. Right. But what did the government learn? What did your agency learn, and where do we go from here?
Bob, that's a big question, and I appreciate it because we've been thinking an awful lot about it. But first, let me say how grateful I am to be here. Any opportunity I have to talk about the work that we're doing is a good morning for me. So thanks. Thanks for having me and for having such a useful series of panels and discussions. So we've learned a lot. We're not the same, and we're not going to be the same coming out of this pandemic. When I think about the ASPR team and all the work that they've done 24/7 around the clock on behalf of the country to get us the vaccines, the therapies, the diagnostics, the supplies that we didn't initially have in the Strategic National Stockpile, to get it restocked, to make sure that we have domestic manufacturing of these supplies moving forward. You know, I'm so proud of all that we've done, but there were things that we didn't have that we needed, that I now know and am asking for. They include some authorities that had us rely on, and we were so grateful for the partnership, but we had to rely on DoD to do our assisted acquisitions. We weren't able to contract as quickly as we needed to get those vaccine candidates, those 6 initial companies that we were working with. We couldn't get them under contract fast enough. And DoD came in with a certain set of authorities that they had and were able to move our contracts much quicker. Well, I'm now asking Congress for those authorities. I won't always be able to rely on DoD, so I think it'll be really helpful if Congress would consider giving that to us, so I can move out. DoD, when it's a whole of government response, is there. Let me be clear: we can all rely on DoD always. Sure. But we need to be able to do the health things so DoD can do the military things, and I think that's just critically important. We also weren't able to staff up as fast as we needed to. We had to rely on FEMA and the Coast Guard, those that had surge hiring authorities and were able to bring people on super fast. We've since been able to staff up, and it's been really helpful to have some of the authorities that were given to us through the supplemental funds, but those are going away now. I think everyone's aware of that, and I'm going to need those moving forward for whatever comes next, hopefully not in our lifetime, Bob, as you mentioned, but I'm going to need to be able to move quickly. You know, we're living in an era of poly-crisis. I can't always have FEMA available. They're going to be out doing wildfires and, and other weather events as we're seeing climate change pick up. I'm going to need to be able to do the health things, so I'm asking Congress to help me do the health things better, faster, moving forward.
There are a lot of people asking Congress for a lot of things now. Where do we stand on you getting that authority?
Well, I've had the opportunity, and I do call it an opportunity, to testify 13 times in front of Congress, just in the 2 years that I've had this job. And each time I go up there, I try to make sure they know how important the work that ASPR is doing is and how critical the teams are, but how we did need help and we didn't have everything we needed at the start, and how fast, how much more we could do, how much faster we could go if we had these authorities. I continue to be optimistic that they're currently doing the Pandemics and All Hazards Preparedness Reauthorization. That was our authorizing bill back in 2006 after Hurricane Katrina. They set up our office. So we continue to look to them every few years to reauthorize those authorities. And I've asked that to be the vehicle that we use to get these additional hiring and acquisitions authorities that I'm seeking coming out of the pandemic. And they're working on it, and they have heard me, and we've had wonderful conversations with several members. So I remain optimistic.
And who are the main players? Because it's a bipartisan initiative.
It's a bipartisan.
But it's going to have to be, right?
Absolutely. So we've got strong leadership in the House on the Energy and Commerce Committee. Both sides of the aisle have been working very closely. Each have designated their lead interlocutor, and we've been working very closely with those offices. Same with the Help Committee. Chairman Sanders has deputized Senator Casey and Senators Romney to work on this. And so we continue to engage and remain available for any technical assistance Congress is looking for to understand exactly why it is we need these authorities moving forward.
And is the timeline the end of the fiscal year that this needs to get done?
That's right.
Okay. And do you think it could get done by then? That's your hope. But obviously, if not, then Congress punts sometimes if they don't have time. We've seen that many times.
Absolutely. We remain optimistic that they'll get it done in time, and we'll continue to engage until it's finished.
Okay. We were talking earlier about drug shortages. Where are we on drug shortages in this country?
Well, I think everyone, if you've been reading the news, you've seen that we have significant drug shortages, which are a big worry for those of us part of the HHS family. The place where ASPR, my organization, plays, we've been able to onshore some critical API. That was one of the things that we were able to do with supplemental funds from COVID. So we've got about $500 million invested in bringing that capacity onshore, but that doesn't solve the larger problem. So we work very closely with FDA. FDA is the organization that the manufacturers work with within HHS when they need to identify that there's a shortage. And we would need additional funds, frankly, if the $500 million that we've invested gets us started on the API that we need in the response framework, for BARDA and other critical medical supplies in times of a crisis. But that doesn't cover oncology. That doesn't cover, general pediatric. There are other places where there are shortages that are being felt that will need to get picked up and answered with additional funding in a new way.
I know we talked about the reauthorization and Congress's role, but can you tell us a little bit more about the reorganization that you've done at ASPR and what it means for patients, how it improves? Because there are a lot of health agencies, and it's very confusing to average consumers.
Well, I really appreciate that question because I'm afraid not everybody understands what we do. And so any opportunity I have, Bob, really to talk about ASPR and the good work of the teams, I take advantage of immediately. So we're the Administration for Strategic Preparedness and Response. We were founded in 2005 after Hurricane Katrina with that 2006 PAPA bill. And we were founded initially as a staff division. And this is a little bit of inside baseball, but we were founded as an office in the Secretary. One of my principal jobs and statutory jobs is to coordinate the department and to be the principal advisor to the Secretary on public health emergency response. So we were initially put in as an extension of his office, and we have operated in that way up until last summer. Even though we were very operational in a lot of ways, we did not serve as a standalone agency like CDC, like FDA, like NIH. We were part of the Office of the Secretary. But realizing how operational we've always been, but how much more operational we've become, how many national programs we run, we needed some independence in order to be able to build the HR capacity that an organization that's under the amount of stress that we are under to respond immediately to public health emergencies. We needed to build our own HR capacity and not just attach to the capacity that was part of the Secretary's office. We needed our own acquisitions capacity. Now, this is the infrastructure. This is the support that we need in order, what should we get the authorities we're asking for to operationalize those authorities. And being a standalone agency within HHS gives us that independence to build like CDC, like FDA, like NIH. And we have a national disaster medical system. We've got teams of clinicians that go out and respond to whatever public health emergencies come out of any disaster. We have the Strategic National Stockpile. I think everyone learned about the Strategic National Stockpile in March 2020 when we opened it up to see what was in it and didn't have the things we need. Well, we've been restocking that as we go. We have BARDA, which is the Biomedical Advanced Research and Development Authority. They're responsible for doing the late-stage development of the countermeasures that we all have relied on these last 3 years, the vaccines, the therapies. And we now have our supply chain work, the industrial base expansion effort to bring in domestic manufacturing of these critical medical supplies. All of those are operational responsibilities that we have. Just to say, the Secretary made us an operating division or a standalone agency when he saw the breadth of everything that we had taken on in COVID. And this gave us the ability to begin to build out the capacity that we need to move forward faster next time. I've also reorged. So when I got into the organization, I came in and was looking for that strategic national stockpile, that thing that captured everybody's attention in early 2020. I couldn't find it on the org chart. I had to look 3 levels down for something as critically important as the Strategic National Stockpile. It did not report directly to me. Well, we did a reorg, which we were able to roll out in January of this year, in which the Strategic National Stockpile, which is the single largest line item I have in my budget, is now an independent office within ASPR that reports directly to me. I needed to have that accountability for something as critical as that is, as well as the increased visibility into the work that they were doing. So that's an example of some of the changes I've been able to make on my own. Mm-hmm. The authorities I'll need help from with Congress as we continue this transformation.
Something that has faded from the headlines, but I did want to ask you about Mpox, and where are we as far as, are you concerned about that coming up again? Where are we in the treatment of it?
So Mpox was one of those things that we were watching this time last year and actually doing significant amount of response work. We were lucky that within the Strategic National Stockpile, we had a small stockpile of a smallpox vaccine that we had purchased for the immunocompromised. It turned out that smallpox vaccine also was licensed by FDA for use in Mpox. And at the time, Mpox was something that we were seeing in other parts of the world, but hadn't really spread widely the way we saw it spread last summer. But as soon as we began to see the way it was spreading, and it was spreading differently through close, intimate contact last summer, we began to look at what we had and make it available, anticipating that it was going to come to the United States. And of course it did, and it came quick. And it was this time of year, June, July, and August, when we really saw the uptick in cases. As we moved out of the summer months, and we deployed on a national level this vaccine, we began to see the case counts go down. In fact, through much of the winter, there were 1 or 2 cases every now and again. But now that we're hitting the summer months again, more activity, more people are out and about, interacting with each other. We are seeing a small cluster in Chicago, and are continuing to watch that very closely. You'll see lots of effort to get the vaccine back out this summer and get ahead of what could be a potential outbreak. But so far, outside of what we're seeing in Chicago, we are very vigilant, but not seeing major worry.
Can you take us behind the scenes about how the government, HHS, ASPR, all these government agencies work to keep track? You mentioned Mpox in Chicago. How do you track all that? Obviously, the coronavirus started in China, but so this is a global. What are the methods to finding out information?
Well, there are a couple of things. We work very closely with CDC, and one of the things I think people don't understand is where we begin and where they end. And so they have the surveillance apparatus in place, the relationships, as do most of us in the department, but close relationships with international colleagues. And so as we're seeing things show up globally, that gets plugged into the CDC forecasting system and their modeling system, and they are watching surveillance. And we rely in ASPR, so this is where we sort of begin and end. So CDC has this data, they do the forecasting, they do the surveillance. When they see a signal, I have the tools in ASPR. So right now, Dr. Walensky and I would look across the table at each other and say, okay, we're seeing this signal for Mpox. Okay. What do we have for vaccines, for therapies? We know we can anticipate we're gonna need vaccines, therapeutics, diagnostics, for most any outbreak that we see nowadays. So I lock in with CDC, see where it is. They have the epidemiological expertise. They're going to tell me how severe it is, where they imagine spread is going to go. I deliver the tools to those places, and together we mount this response.
Looking forward over the next year, 5 years, what are you most concerned about?
Well, there are a couple of things. This is a great question. And I spend my nights up so you guys can sleep well, I hope. We worry about a lot. We're seeing, I mentioned polycrisis. We're seeing things happen, not one wildfire at a time or one tornado or hurricane at a time, but having them happen at the same time, simultaneously. Do we have enough staff to be able to keep a response going on a multi-front? And people may not realize, throughout COVID, we were continuing to respond to various disasters and public health emergencies. While we were doing COVID and running, that 3-year acute response, we were also, like last summer, had our largest hurricane deployment after Hurricane Ian in Florida. We also were watching very closely the Marburg outbreak right now, but in Tanzania and in Equatorial Guinea, and wondering if our investigational vaccines and therapeutics needed to be deployed there. We did deploy some to Uganda for the Ebola Sudan response that they had. So we continue to do all of this, but I worry that as these are multiplying, as they're becoming more severe, do we have enough? The other thing I worry about is that thing that we didn't expect. If we were sitting here in 2018, everyone would have said the next big thing is going to be a highly virulent flu. And we would have all been preparing for what that would mean. Well, we were right, it was a respiratory illness, but it was a coronavirus. And while we were all thinking about what it would mean to be ready for a pan flu outbreak, which would be extraordinarily severe, Corona came in the, in the living room window while we had the front and back door locked. Are we looking at those things? Are we not just preparing for what happened, but for what could happen? And BARDA has taken on a threat agnostic approach. They're really looking not at one bug, one drug anymore, but they're looking at solving, the symptomatic responses to any threat that could come. And I think that will give us a few more tools that we need to respond to those things that we don't expect.
Last question, because it's now something more of a new phenomenon, as we talked with Dr. Fauci, misinformation. How do you deal with that?
Well, that is a challenge, and it's something that we continue to wrestle with within HHS and, of course, across this administration. One of the things that we do at ASPR is make sure that we, model correct and appropriate behavior and make sure that we are not giving any, just any opportunity for anyone to question the decisions that we're making. We try to be very transparent about why we were making a decision, what we know, what we don't know, what we're doing, what we expect you to do, and that could change depending on the science as it comes in. So we've just tried to be very transparent, but it is a problem, and it's something that we're all going to have to wrestle with.
Absolutely, and also the role of the media as well.
Yeah.
Dawn O'Connell, thanks for joining us. Really appreciate it.
Thank you.
Thank you so much. Appreciate it.